Okay, I'm going to talk about what's happening with, you'll notice I didn't say managed care, I said managing care, meaning I'm going to give you a couple of examples and scenarios of things going on in Ohio that are instructive with regard to our field here. Okay, so we're going to talk about the current initiatives that are going on with ABD kids, with health homes, talk a little bit about MyCare, which is some really interesting lessons for us, and how some of these things are going to potentially impact you. All right, so remember that our current framework in Ohio is very heavily a managed care platform. So our current, Medicaid director, John McCarthy, feels very strongly about including as many people in managed care as is possible. So this slide and the next slide are a summary of where we stand in Ohio with regard to individuals who are covered or required to be in managed care and those not. Okay? So first, we are almost now in Ohio 100% mandatory enrollment with a couple of exceptions, and they do affect you. Currently, adults and kids in institutions, so that's going to be developmental centers, it's going to be psychiatric hospitals, it's going to be, in some cases, even regular medical hospitals are excluded. Anyone on spend down today is excluded. Anyone, adult or child, on a waiver today is excluded. And currently, adults and children who are dually eligible for Medicare and Medicaid are also excluded, with the exception of our new MyCare pilot that I'm going to talk a little bit about. And we also have a small subset of children who, by a statutory amendment in the budget law, excludes a small subset of Title V or BCMH children who have CF, cancer, or hemophilia, and that's kind of a time-limited exclusion. Now that group that I just went through, those individuals are not allowed to be in managed care. Okay, can't even voluntarily choose. They're not allowed. This group is not required to be mandatory, but can voluntarily choose to participate in managed care, and they can go on and off of managed care. And here then is the young folks under 19 years of age who fall into these different categories: foster care, Title V, or adoption assistance, and our BCMH caseload, those with medically complicated children. Now, one pilot or one kind of example I want to share with you is, as of last July, the state mandatorily is enrolling aged, blind, disabled children in managed care. So previously they were not required to be in managed care, now they are. And with the exception of that little subset of children that have CF and hemophilia and tumors, it's about 37,000 kids. It began last July. And these are, of course, the most complicated youth that we have. It's a small number, obviously. We have 1.2 or 1.3 million children. This is a very small number, but they are the expensive, really complicated, involved kids. And so there's been a lot of attention to this, and we'll continue to kind of watch it as an example of how the state responds to it. A couple of observations about it that are instructive. Number one, they're finding that, so this is, we now have these medically complicated kids in mandatory managed care, and there are some lessons that we're already learning. First, the home health services that these kids rely upon obviously very similar to the kinds of services you provide. Those services are a consistent problem. They are having a great deal of difficulty with home health on the panels of the managed care plans and on those kids being able to access that kind of service. We're also finding that in some cases, although it is not as prevalent as people feared, the kids are not able to get when they need a really specialized physician or really specialized medical professional. There are still some instances when managed care plans do not have those on their panel, and the families are having trouble getting access to those. But it actually is turning out to be less problems than folks identified, but still worth watching and instructive. And I would say one interesting kind of sub-story here is that a number of the advocacy organizations got together and really worked with the state to put some additional requirements in place around care coordination for these kids. So that's another kind of interesting side. It's instructive because the state was then responsive to some of the pressure and concerns that people had about these kids. Okay, another example that I want to talk a little bit about is what's happening with the health home movement in Ohio. So we have a couple of initiatives in Ohio that are all in this kind of category. We have what's referred to as the SPMI, serious persistently mentally ill pilot, or this people with serious emotional disturbances, that's being administered through ODMH-AS. But there's a couple of other ones kind of in the works. There is a pediatric primary care, primary medical home project or model that's being developed. It hasn't been unveiled yet by the administration, but there's some work going on there with physicians and more of a medical model. And I'm going to tell you in a few minutes a little bit about the work that OPERA is doing around potentially a DD health home. A couple of the updates on this one. I know we've talked about this quite a bit with OPERA folks over the last 2 years or so. There has been some pretty significant shift over the life of it, and so there was a great deal of optimism and hope about this particular approach, and it's been dampened somewhat by some of the design changes that have occurred. So there was, it's brand new. The administration got into it, but then they started to kind of change the rules. Some understandably so, but the kinds of changes that we've now seen occur, and this is the SPMI one, is they've made the provider requirements more stringent over the time that the phase 1 group's been working. They've added administrative and data reporting requirements and made them have to be done up front sooner than the capabilities were necessarily in place. So it is still likely to go forward, but certainly in a much more limited way than we had anticipated when they first unveiled it. And probably, most significantly, the initial design was a provider-specific payment rate, and that's now been abandoned in favor of an average rate, which, of course, the providers are having a fair amount of difficulty with around sustainability of the program, given the cost. So it will go forward, but in a more limited way. Now, given that, we're going to shift a little bit to what OPERA is doing with the DD health home. So, the question is, why even consider the health home model within the DD arena? And there's some pretty important justifications for thinking about it. Individuals with disabilities disproportionately are affected by other chronic conditions. And we see very high utilization of medical as well as long-term service and support services. So, of course, the Health Home Initiative, particularly as Ohio's leadership has looked at it, it is with much more of an eye towards saving money as well as improving cost, but being sure that that savings can be generated through the work. That's pretty much been the expectation, that all the different areas of state government who are looking at it are being expected to kind of work within as a requirement. And we also feel that providers of service to individuals with IDD are really ideal entities to coordinate services, not only on the long-term service and support side, but also in terms of the continuum of their medical and other kinds of support services. So, obviously your relationships are long-term and you have much more knowledge of individuals, and so it made this kind of a logical concept or program to be considered in the IDD arena. So Opera's had quite a bit of discussion with Director McCarthy, Greg Moody, and others in the administration, and has put forward a proposal, first in the budget language, as you can see there on the top, expressing the intent. And then since that time, specific work has been done, and a proposal is being kind of finalized with, checking back with the administration from time to time. And so here's kind of where we're landing, with a target population of individuals with one or more chronic conditions, and developmental disabilities or intellectual and other developmental disabilities is considered or can be considered by a state to be a chronic condition. And it would be applicable to individuals receiving waiver services, so not individuals served in an ICFMR or ICF-IDD, but those served in waivers. Oops, sorry, wrong direction. The program design, or the idea here, would be to utilize the existing provider relationships and infrastructure. Would be done on a pilot basis, so a small number of counties or areas as the first step, and that is what was done with the mental health one as well, kind of in a phased-in way, and are looking to use certified or licensed existing DD providers as the health home provider, and then utilizing a similar kind of team set of requirements, much of which is specified in the federal law. And for those of you who haven't followed this as closely, what may be helpful to understand is that it does provide 90% federal money to the state for a period of 8 quarters or 2 years. So there's kind of a fiscal boost to the state to help them consider and try some of these sort of innovative approaches. Obviously, as we talked this morning, and similarly here, we'll need to be looking at the overall issue of care coordination and the role of the SSAs. So that's the IDD health home. Now, one other kind of scenario or example is the MyCare. And this is a program that was started just on May 1, although it had been in the works for quite some time. It is Ohio's integrated care delivery system, and it is specifically for those who are fully Medicare eligible and fully Medicaid eligible. This kind of a program was not possible before the healthcare reform law passed, because of some of the constraints on Medicare. So the ability then to even try this really is a very recent option for states. Ohio is the third approved in the country to try this. And as you can see here, we're looking at integrating not only the physical and medical services, but also the long-term service and supports. So we'll see in a minute how existing home and community-based waiver services, like what some of you provide, is being brought underneath this managed care idea. What's also interesting is that in this case, the behavioral health services are also being incorporated into this model. So what today is a carve-out with our community behavioral health services, they're all being rolled in and are the responsibility of the managed care plan. As I mentioned, it is a managed care platform, so the managed care company is taking on the responsibility for individuals, Medicare, Medicaid eligible, for this full array of services. I'm going to show you a picture of the regions. It's being brought up basically in catchment areas around the urban areas, 29 counties. And again, the first went live on May 1, and the rest of them will phase in by approximately July 1. So June 1 and July 1 has some further phase-in dates. So you can see from the map, this is the regions that are part of the MyCare, 29 counties, and as you can see, they're all kind of organized around the major metros in order to have the numbers of individuals that are needed for the actuarial or risk sharing. Really don't know at this point whether there is an intention or an expectation for this to go statewide. I mean, this is a pretty big experiment in and of itself. So right now, focused on the 29 counties. This is another kind of interesting aspect of this, is that it is actually a three-way contract between two arms of CMS and the state. So it is Medicare and Medicaid at the federal level, so both halves of CMS are sitting at the table with the state agency, in this case Ohio, negotiating what this whole plan will look like. Ohio's proposal or Ohio's plan includes mandatory enrollment for Medicaid, but voluntary enrollment for Medicare. So an individual could opt out for Medicare services, but they would not have a choice to opt out for Medicaid. Now, honestly, there's not a lot of real good reasons I can think of. I mean, there are some, but there isn't a lot of really obvious reasons why people would choose to opt out on Medicare. So, really people are expecting that folks would remain for both Medicaid and Medicare. There are some individuals who are excluded from enrolling, and that includes individuals in the IDD arena. So folks that are on waivers, folks that are in ICFs are not allowed to participate, but it does include individuals with mental illness, for example. So Medicare, Medicaid eligible, and it does not include children. So folks under 18 are not eligible to enroll. So where folks are coming from for this, and again, part of why I'm running through this is it really is a very interesting, pretty complicated project that Ohio has taken on. It's intended to bring together not only managed care, but the waiver services and the medical and the long-term support. So we are watching this very closely as something that probably will tell us a lot about what we can expect in this arena in the days ahead. So, for example, where most of the folks will come from in this program is going to be from other of the aging waivers, okay? Folks coming out of hospitals, people who may now be at home but will newly require long-term service and support. That's the group of folks who you could expect to see in this kind of a project. And what's kind of interesting is that as they're bringing together all these different waivers, they're allowing individuals to receive any of the services on any of the waivers. So, for example, assisted living is only currently available through the assisted living waiver. With this, as they merge all these together, they're saying anyone on this program will have access to everything that is currently available. So where we have different benefit packages, that will all be erased, all the boundaries will be erased, and it really then is a complete and full array of services that would be available to everyone who served on this MyCare. A couple other things that are kind of interesting about it. The state's been fairly deliberate about transition. So, for example, individuals who, like the second one is probably most helpful. If an individual is coming into the MyCare program and they currently have a relationship with any number of those kind of providers, so if they have personal care services or adult day services or counseling or any of those kind of existing services, when they come into it, they're allowed to maintain that relationship for 365 days. But then after that period of time, or if the managed care plan decides sooner than that, that the individual's needs are not being appropriately met, but it provides kind of a transition or a soft landing and some ability to maintain continuity of care. Same thing on the behavioral health side. If the person's receiving services, there's an automatic transition there, and that'll, hopefully not only cut down on some of the fear and concern that these older individuals may have, but it certainly has lessened some of the concerns of the providers who, and certainly the managed care plans are setting up networks that are not going to include every one of our current providers. Okay, so just, to kind of sum it up, what's instructive and interesting about MyCare, it is Medicare and Medicaid, and as you know, many of the folks you serve are duly eligible as well, particularly adults. It is a managed care plan or platform as the single point of contact. Individual has a choice among the managed care plans of who they want to work with. They cannot opt out for Medicaid services. They can opt out for Medicare services. There's a whole host of, like what we saw earlier with the HCBS requirements, a whole host of person-centered plan and person-centered choice components to this that I didn't spend any time on, obviously. And it is explicitly intended to be integrating the full array of physical, behavioral, as well as the long-term service and support services. So that's a couple of interesting examples going on in Ohio that will give us some clues about what we can expect. And I think, as Gary mentioned at the beginning, I wholeheartedly agree with him. We may not see a simple, just take everyone in the DD field and just sort of plop them all into a managed care plan. But what you are seeing, even with these examples, is those managing care tools are absolutely being brought, even now, into some of the areas with individuals with disabilities that typically were not ever looked at as much for managed care. So good examples for us as we look at the months and years ahead. All right, now our fourth segment then, I'm going to turn it back over to Gary, and Suzanne and I will certainly be chiming in, is we want to now kind of take all of this and sort of bring it together with a big red bow, and at the same time draw in some of the financial lessons and considerations for you.